Order! Order! You are an incorrigible delinquent at times. Behave yourself, man!
For today's tracker, we've turned our attention to another key government department facing some big questions over its role in the post-Brexit landscape, the Department for Health. With around 130,000 EU nationals working in the health and social care sector, politicians and their civil servants in the Department of Health will be heavily involved in negotiations over immigration policy, and particularly what system of work permits will be available for health workers post-Brexit. The EU forces each member to accept each other's medics and nurses as equally qualified. Will Brexit allow Britain to demand higher standards of qualification for its healthcare workers, or will reciprocal recognition continue? The UK already has its own regulatory body for licensing new drugs, though many companies prefer to go through the European Medicines Agency that covers all EU markets. If we leave that, some campaigners believe drugs could be made available more quickly. One of the most visible benefits to EU membership is the European Health Insurance Card, which guarantees free healthcare when abroad and brings down the cost of travel insurance. Will a new deal be negotiated, or will the UK form a series of bilateral agreements with major destinations? The EU currently coordinates responses to pandemics through its European Centre for Disease Control and Prevention. Will we continue to work with the agency after Brexit? And if so, will we have more access than Norway and Switzerland, which work with it but do not make decisions? Currently, NHS procurement has to follow EU-mandated standards, which many believe leaves it uncompetitive. Will new legislation after Brexit allow for greater efficiencies, freeing up money for patient treatment? These are just some of the issues Health Secretary Jeremy Hunt and his team have on their plates as the government moves ever closer to triggering Article 50 and firing the starting gun on our exit from the EU by next March.
Can't wait.
And to discuss all that, we're joined by Andrew Lansley, the Health Secretary from 2010 to 2012. And you two behave. Now, the NHS relies heavily on EU nationals, and there's been a lot of discussion about it. So surely not even the most hardened lever would begrudge those who come here to look after our sick when it comes to freedom of movement and immigration controls.
Well, this is one of the central issues for the health service and indeed for life science companies. The first thing they say is we want to have access to the best people and the number of people we need, because we're talking about 10,000 doctors, 20,000 nurses, 90,000 people in the care sector from elsewhere in the European Union. Now, to be fair, the Brexit, I was a Remainer, but the Brexiteers, they're pretty clear about this. They say it's not necessarily about numbers, it's about taking back control. So if we want to have doctors from abroad, if we want to have nurses from abroad, if we want to have Filipino nurses, if we want to have a very good nurses training system in the Philippines,
will still happen.
That they can say, look, nurses are on the shortage list for the migration committee, so we can recruit nurses from all over the world. So they would say, look, it's possible to do this thing. It just doesn't mean necessarily that immigration numbers go down.
Right, and if immigration numbers don't go down, that may cause another row amongst the people who did support the idea of leaving. Beyond taking back control, they did want to see fewer immigrants coming. But yes, let's take those numbers in the care industry and in terms of doctors and nurses. Would it not be better if we trained British workers to do the same jobs? Clearly, that would take some time.
Of course. And it does take a long time. And, I can remember when I was Secretary of State, I wanted more emergency doctors. They just weren't in this country. Right. We had to go abroad.
So how long would that take, do you think, to build up the numbers?
For doctors, you're talking a 10-year time lag. For nurses, you're taking about 5-year time lag. There's things being done in terms of returns.
I'm puzzled about this. Why is it we can't train up our own doctors? This has been an issue now, literally
funding,
for 25 years. Well, why don't we invest in it?
The issue, you will understand why I say it. It's about actually the role of the BMA in particular. And we have constraints on the number of British doctors, but we have the most expensive doctors in Europe.
Right.
That's why actually for a German doctor to come and work the weekend in Britain
I saw
is
that.
highly attractive.
Right, but when you say constraints,
that's mainly about agency fees, though. That's not actually because our NHS pays doctors more than
as it
anybody
happens,
else.
we do pay doctors more.
But why don't we explode the number of...
The main problem is the agency fees, and that is about
the issue is
a
training
failure
more
of joint
doctors.
up
We should train more doctors.
Yeah.
Of course we could.
But
But
I
it
don't
was
know, but
always
you're
constrained.
Don't talk over each other. But why didn't
was-
it happen when you were?
It didn't happen. Well, it had just been expanded. The Labour government, just before 2010, set up new medical schools. So we were in the process of increasing the number of doctors in training. But the constraint was the number of training places available in hospitals.
But that is a key problem. There would be a big gap if we lost a significant number of doctors and nurses and care staff.
But I'm
That's
hopeful
clear.
that we won't.
So, right,
I'm
you're hopeful
hopeful
that the UK won't lose them. What kind of permit system, let's say there was a work visa permit system that came into play for EU nationals, what sort of system would you like to see so that we could still have those doctors and nurses that the country needs?
Well, it's going to look like the Tier 2 visas, isn't it? It's going to be something of that order, because it's bound to be relatively equivalent between European workers and those coming from elsewhere
I
around
went
the
and
world.
worked in America. I went and worked in America, and actually you had to go through some hoops and jumps and everything. But it wasn't the end of the world.
But it
Let's
could
be
make it more
realistic about
difficult.
this. It is quite difficult relative to coming and working elsewhere
funnily
in
enough,
Europe.
The care sector is slightly different in the sense that the care workers have been actively recruited. I don't think the kind of evidence isn't there they bring down wages, but basically the fact is that people who live here and have families here cannot afford to work as care workers, leastwise not in London. And so 80% of London care workers have been recruited from the Philippines or from Kenya now, or from somewhere other than the UK. Now, the point is that is just creating a kind of low-wage economy within a particular sector. So to say we need to protect that as a visa requirement, we'll put you head-to-head with everybody who ever said immigration is bringing down wages.
Right, and also, if we move on to the reciprocal arrangement at the moment, that means professional qualifications are recognised here and between the European Union states. So you can have a nurse from one EU member state, her qualifications are recognised here, and vice versa, someone from here over there. Should we remain part of that scheme?
I think we would. I mean, most of the things we've been talking about here, including the reciprocal healthcare arrangements, I think actually there is, on the face of it, a good reason on both sides to come to an agreement about it. But it's never going to be quite that straightforward because health, like some of the other issues you've been discussing in this series, is going to get complicated by the point at which the Europeans say, well, hang on a minute, you can't have all the benefits of being in the European Union without meeting all the obligations.
And isn't that the problem, though, Kelvin Mackenzie, that in the end, if there is a feeling that we are trying to opt back in or maintain reciprocal arrangements, not just in health, but in all sorts of other areas, on the one side, there'll be leavers who say, well, look, we're not really leaving the EU. And on the other side, member states will be saying, you just can't have everything the way it was because you've left.
Well, look, I don't know. The UK economy is a fantastic economy. It's creating loads of jobs.
Sure, but it's not that simple.
The demand to come here is far outstripping even the number of jobs that we've got to supply. I am not worried for one single second that we aren't going to be able to fill all the jobs that are required. There may be some difficulty on the management side. I couldn't care less.
Hang on, I'm just going to let Zoe Williams finish.
That doesn't answer the question at all, does it? Because what we're talking about now is reciprocal arrangements, and those cover a huge amount, including legislation and the kind of regulatory framework that allow us to cooperate with Europe. Now, we've got a massive, massive job of work to do here to either establish our own frameworks or to buy back into the EU's. And we've got to stop talking about this as though it were only an immigration issue.
Right. Zoe's absolutely right about that. Let me give you one example. We've just finished the process, virtually, of negotiating the new medical devices regulations all across Europe. The best people for doing this regulation are the Medicines and Healthcare Regulatory Agency in Britain. They're the leaders. We've got the best regulators in Europe.
Right.
And so there is an obvious negotiable arrangement that says we're still in this thing. We're in clinical trials because we want to have European-wide clinical trials. We're in the research programme and we're willing to pay into it. We're willing to be part of the regulatory system, and they would want us to be part of the regulatory system.
And why wouldn't other European countries want us to continue to be?
Because at some point, politics will interfere with this thing. That's my worry.
That's a worry, but you don't know that, though, do you?
European health insurance cards...
Right, well, let's talk about the European health insurance cards, because we all know what those are. When you go abroad, you take them with you, and it gives you access to the health services abroad in other EU member states.
And the government pays.
That's right.
Yeah.
You would still want to be part of that scheme?
Well, I mean, I think from the public's point of view, we would. Yeah, of course we would. But firstly, we need to know whether the government wants to be, because it's going to cost them about 600 million a year to be part of this thing. And then secondly, how does that work? We've kind of got, if we say, if you travel to Spain, you can have this card that means we'll pay for your health care. If you travel to Morocco, we're not paying for you. Why, on what basis is the British government going to discriminate? On the basis maybe of a reciprocal arrangement, if a Moroccan comes to Britain, they'll pay for his health care. Yeah, the newspapers today say that we're 30 million light on what's being paid for people coming here. We're not that great. We need to get a lot better at making sure that people whose governments should pay for them to be here do pay.
Right, and in that sense, do you think that these, I use the word details, but they're not details to a lot of people, things like the European Health Insurance Card Scheme, that this may get lost in what will be a very big negotiation on Brexit?
Well, there are going to be 1,000,001 problems that face us exiting. By the way, all solvable. They were all created by humans. They will be solved by humans. I am not worried. And by the way, when people come over here, they get basically free health, no matter which part of the world they come from.
But the politics is going to be dreadful.
Andrew Lansley, thank you very much for coming in.